Hello, today we'll be discussing menstrual disorders and the associated factors among adolescent girls visiting a youth clinic. This particular study was published in a Gynecology and Obstetrics journal from Sweden. Menstrual irregularities can be caused by disruptions of the hypothalamic-pituitary gonadal axis, also known as the HPG axis. The question we'll be examining today are what are the mechanisms and the associated factors of oligomenohrea and secondary amenorrhea. Here are some key terms that we'll be discussing today: the hypothalamic-pituitary gonadal axis, follicle-stimulating hormone, luteinizing hormone, testosterone, and estrogen. I bet you're wondering what in the world is the hypothalamic-pituitary gonadal axis. I'm here to tell you. It consists of three organs: the hypothalamus, the anterior pituitary, which happen to be located within the brain, and then the female gonads, which are the ovaries. The hormones function in negative and positive feedback loops to create communications between these three parts of the body. FSH stimulates follicle development in the ovaries. LH stimulates the secretory phase of the uterine cycle. Estrogen stimulates the proliferation phase of the uterine cycle, and progesterone signals pregnancy and helps prevent other eggs from being released after ovulation. Together, these hormones function to regulate the human reproductive cycle. Secondary amenorrhea is a lack of periods for at least 6 months after having ovulated at least once. Oligomenohrea is infrequent uterine bleeding with at least 35 days between each episode. The hypothesis of this study was environmental factors and endocrine disturbances can result in oligomenohrea or secondary amenorrhea. In this study, there were 203 girls with secondary menstrual disorders. A clinical exam was performed by a gynecologist, and a nutritionist was consulted if the girl had any eating disorders. Blood samples were taken. There was a detailed history, including many factors, and the appropriate statistics were used to compare the two samples. Here are the factors in which there was a difference between the two samples: weight, BMI, LH and FSH levels and ratios, SHB, which binds to sex hormones, which would be estrogen in this case, testosterone, prolactin, eating disorders, and problems with family or friends. Here are some factors where there were no change: free TH, which is indicative of thyroid functioning; age of menarche, which is when a girl first gets her period; pulse rate, the age at which weight loss started; smoking and alcohol use; cohabitation with parents; and the problems in the school. Here are the conclusions for the girls with secondary amenorrhea. Low progesterone levels indicated that they probably had a low level of estrogen. Low estrogen is probably caused by a low secretion of LH, since this exists in a positive feedback loop. The hypothalamic inhibition of the HPG axis is usually an acquired functional disturbance, meaning that something in their body or their life had to change for them to develop this particular. The lower BMI, increased weight loss, and the high frequency of anorexia indicates the girls were probably suffering from starvation. It has been a proven link that starvation can lead to hypothalamic inhibition. Here are the results for girls with oligomenohrea. They showed a high LH to FH ratio, increased testosterone, and increased SHBC, which indicates that they had high estrogen levels. All these are indicative of androgen excess. The high frequency of polycystic ovarian syndrome has been associated with androgen excess. There is also a possible link to bulimia, given this was the major type of eating disorder found. There was also a higher frequency of parental alcohol and drug abuse, indicating increased family stress. So here we are at the summary. Hypothalamic inhibition of the HPG axis has been associated with secondary amenorrhea. Hyperandrogenism is associated with oligomenohrea. The large proportion of the girls had eating disorders. Starvation caused by the eating disorders made their hormone levels change and altered their menstrual cycles. There's also the factors of physical activity and family stress, which also need to be further investigated. Here are some questions to think about. How are bulimia and oligomenohrea related? How does physical activity affect the menstrual cycle? Will treatment for the eating disorders return the HPG axis back to normal, or is further hormone treatment needed to fix this issue? And what is the relationship between these disorders and their associated causes? Is it correlational or causal? I hope you understand how disruptions of the HPG axis can impact people's lives. HPG disruptions cause different syndromes in males and females. It is important that research be done to help these individuals become healthier.